this panel essentially is going to bring out a lot of relevant points in our clinical practice, which we come across as oncologists and pulmonologists, and we keep on fighting with each other, saying कि चलो इसको biopsy करो, and at times the pulmonologists say कि no, hold on, let's wait, monitor it for 3 weeks, we'll repeat a scan after 3 weeks, and that give and take keeps on happening. So we thought that this will be a good session in terms of discussion to know about what each other's perspective is and how one goes about it. So just to set the ball rolling in each one of your practices, what is the overall incidence of these mediastinal lymphadenopathies that you see in patients who have extrathoracic malignancies? And if you can enumerate the commonest ones that you see in practice, Uma, we start from it.
So we do see a lot of mediastinal lymphadenopathy, and in a country like India, I think we see a lot of lymph nodes which may not really contribute to the malignancy. But off the top of my head, I would say testicular malignancies, some ovarian malignancies can also involve the retroperitoneal nodes and go up to the mediastinal nodes. Head and neck malignancies are common, even esophageal malignancies, or they can cause mediastinal lymphadenopathy.
Sure.
So since we're a referral center with SOP, so we see a mixed group of diseases. So breast, lung, as well as GI, but also a lot of non-cancerous diseases like tuberculosis, sarcoidosis are there in extrathoracic malignancies as well.
Yes. Sure.
So one very common presentation many times I get from oncologists is that the primary site lesions are recovering but the new PET CT is showing mediastinal lymph nodes.
Yes.
And now they're worried, primary extrathoracic side, everything is getting under control, but mediastinal lymph node, now this is a worry. Now they want me to answer it. So many times we have to, we ask them to undergo biopsy, and sometimes patient is not affordable. And we just have to watch, because sometimes it is granulomatous disease, could be TB, could be sarcoid-like reaction also, which is very often we see. So that is what I see.
Sure. Kiran, your practice.
Other than solid malignancy, the lymphomas, Hodgkin, non-Hodgkin, and TALL, these are common.
Yes.
And breast also we are seeing the
Absolutely. So I think most of us, we do see patients with head and neck, patients with renal cell carcinomas, and also patients with testicular tumors as a part of solid malignancies that are commonly present with mediastinal lymphadenopathy, in which we need some kind of tissue diagnosis. Either it may be along with the diagnosis of primary or as a secondary spread later on. And of course, lymphomas where either primary mediastinal lymphomas or as involvement along with systemic therapy. Arjun, any comments further?
Yeah. So how much are the nodes that we are picking up are because of the fact that we are doing a lot more of PET these days? Because when you look at it, primarily there was no node, and then they've undergone chemo, and subsequently the primary disease has gone down. That's the usual thing. That's what we see commonly. Now then a PET is done to look at it, and then these small nodes, 1 centimeter nodes, which are about 2.5, 3, in the as far as the intensity is concerned, and that's when we are subject. And nobody has any idea whether to biopsy or not to biopsy, and whether it is tuberculosis. And again, considering the fact that it might be tuberculosis also, or it might be sarcoid-like reaction.
So what is an SUV that you feel significant that you should go ahead and biopsy versus watch and wait?
So it's not always the SUV that guides me. It's also the primary. So suppose if it's a head and neck patient who has come with a mediastinal lymph node, I would definitely push for a biopsy, because that would change my line of management completely. Yes, but if there is suppose a CA colon, and that there are no liver mets, no other metastases, but there's just some highlighted mediastinal lymph node, I would be probably more closely observing it and not try to push for biopsy in such situations. So it depends upon where it is coming from. And if we were talking about lymphoma, so in lymphoma I really don't need to separately biopsy the mediastinal node, so that's
sure. Kiran, your perspective on this?
Sir, SUV also, and another with short axis diameter. We'll discuss with the radiologist. They are thinking of the benign or the malignant. This first isolated mediastinal lymphadenopathy is also a rare phenomena, but we have to discuss with the multidisciplinary, with radiation, with the radiologist, with the pulmonologist also, then we can discuss.
Sure. Interestingly, there have been multiple series which have been reported which say that if a PET positive mediastinal lymph node which has an SUV between 2 to 3 and a maximum diameter of less than 2 centimeters has been biopsied, only 33% of the time it has turned to be malignant. There is Indian data which is published in Indian Journal of Cancer. The article is available ahead of print now on the site's journal, and it's an interesting data from Delhi State Cancer Institute itself. So,
but having said that, if you say that 1/3 of them are malignancy, still I think it's worth biopsying them.
It's still worth biopsying. So in fact, I actually expected an incidence of much lesser, and I was surprised to see that article saying that 33% of mediastinal nodes in patients who have extrathoracic malignancies actually turn out to be malignant.
One of the things has been, the challenge has been to differentiate a sarcoid reaction versus tuberculosis. You know, it's not often that you would get a gene expert or a culture positive. You see it granulomas. So from an oncologist perspective, suppose, you know, you've sent a patient, I've sent you a patient back with granulomas. How do you interpret? How does it, I mean, how do you guys go ahead?
So honestly,
This time it is not malignancy, they are
I was
okay.
just going to
Yeah,
say, if it is granulomas, it's beyond me.
It is TB. Suppose it is TB and you want to give
So-
chemotherapy.
No, so yeah, so if then I would send it back to you, ask if you want to give AKT. No, that's a joke.
I'm saying difference. I mean, the difference. You're not sure.
No, so I agree, because it's a granulomatous. It may or may
If
not
gene
be.
expert is negative.
And gene, so if gene expert is negative, patient is not very symptomatic, and depending upon what kind of chemotherapy I'm going to give the patient, I would not really probe, but I would probably keep a watch on that. Maybe repeat a CT after a couple of months to see what is happening with that node, and then take a call from there.
Arjun?
Kiran, your thought on this? Giving AKT, observing.
If the granulomatous, I will give AKT, because in India, tuberculosis is much more common as compared to the other diseases.
So we've come across this situation previously where I was working at Prince Ali Khan. We used to have a lot of head and neck patients who used to undergo neck dissection, 30, 40, 50 nodes removed, and few of them showing granulomatous disease. And there, this dilemma always, the surgeon would always refer to us saying, oh, you start with radiation and chemo post-operatively, but what are you going to do about these granulomatous nodes? And practically in most of these patients, the gene expert was negative, the culture was negative, and we've not treated a single patient with AKT, and we've kept them in observation. And about 40 patients, at least I remember offhand, that we've had this data, and none of them have actually transformed into tuberculosis later on. So if the patient is an asymptomatic detection of only granulomatous lymphadenitis, we don't know whether it is sarcoid, we don't know whether it is because of COX or something which is a latent tuberculosis, which is very common in our country. We've not really treated them.
So in this case, a new onset of lymph nodes, which were not there on the earlier scan. New onset PET positive lymph node. So does that make a difference, or you could have these lymph nodes coming up in a, you know, which could be just a sarcoid reaction which were not there earlier?
No, so if there are new nodes coming up, anything that looks new, we would definitely want to biopsy if it's easy, because we want to, firstly, because patient has been immunosuppressed, patient has been on, you know, chemotherapy, and if there is more treatment to come, I want to make sure that, you know, there is not an underlying infection which may flare up and make the patient more sick. Secondly, I'd also, if there is even a slight suspicion whether this is disease progression or whether this is just something else. So without a biopsy, I am not very comfortable moving forward.
Yeah, I think regarding starting ATT, unless and until there is, if you find that radiologically the node appears necrotic, and either you have gene expert positivity or the patient is having constitutional symptoms at that point of time, that is when we start ATT. Otherwise, we tend to observe till the cultures come back.
So many a times in this scenario where a follow-up scan is done for a patient who's otherwise healthy, is in remission for a certain number of time, and then a follow-up scan is done, we tend to see some few paratracheal or subcarinal nodes. So what is a pulmonologist's approach in such situations? I would want to know from
Any node that is there, we'll biopsy if you send it to us.
Because patients come to us directly with the reports, one tiny subcarinal node, sub-centimeter, 0.9 centimeter, and a right paratracheal node, which is about 1.2 centimeter. As per the size criteria, what would you take as a significant size of the node to trigger that thought in your mind saying, yes, you should biopsy?
At least for the medical legal purpose also, we have to biopsy.
No, if it is more than a centimeter, I think new onset more than a centimeter,
Sure.
I mean.
So it has been unusual. Again, we might have a referral bias. So whatever we've seen patients 8 years in remission, so somehow they decided, haven't said hi to the oncology team. They undergo a PET scan or of somebody, and then they find a lymph node. It's turned out to be metastatic.
Yes.
We've seen that after a gap of several years of remission also. So I think there is no way of saying. So I think if something is identified, I think you either disprove the malignancy. And of course, if it is a non-malignancy and you've got granulomas, then that helps you to say, okay, I might observe something. But a negative lymph node, if EBUS is negative, you don't have granulomas, you have nothing, and you've got a PET positive lymph node, I think then we tend to put for a second procedure.
Okay. Uma, any thoughts?
Usually, if I think we usually send for a EBS-FN, NA, and along with that a biopsy of the lymph node, because always as oncologists, I think we are more comfortable with biopsy than cytologies. As far as if like you said, anything that you see you want to biopsy, but we also take it in the clinical context. So suppose there are no retroperitoneal lymph nodes and there's only one mediastinal node or something like that, which is which is unusual, which is not fitting with the diagnosis, and which is very tiny. Maybe it looks it's not very necrotic, and the radiologist says it's like a gray area. There, I would probably tend to observe, maybe repeat a scan and see where it is going.
Yeah, so I think what has happened is often we've seen this approach from our colleagues, and I think people have got a scan in 3 to 6 months, and for 3 months at least, if it is persistent, then they've been referred. So I think that what you're seeing really reflects the practice. As far as the biopsy is concerned, I think there's cell blocks done at a few labs, again brilliant results. So what we are doing is we are not trying to separate. We've been done that. We've published that also, showing cores, send them separately, slide separately. Now we've really started to push everything into formalin. Madam does it, and you get fantastic results with that. So irrespective of really you have a big core or not, the aspirate into the formalin gives very good results.
And again, like Dr. Prashant mentioned, it also depends on the time frame, right? I mean, he said after 7 years you got metastasis, but after 7 years you also have to. It may be completely unrelated to the basic disease. It might be it might be tuberculosis, or it might be something else. Yeah, it could be a different malignancy too. So.
Yes. I think any more things from your side?
Kamlesh?
Yeah. So I recently, I'm sharing my experience. Recently had a patient who had a similar situation. The primary disease was under control, and now she had this classical presentation of fatigue. She had fatigue, and she on HRCT she had features of sarcoidosis. She also had hypercalcemia, but again there were some nodules. So I did a bronchoscopy, lavage, and endobronchial biopsy. Everything turned out to be negative. But since I did not have a EBUS done, we were not sure. But her symptoms were clinically fitting into sarcoidosis. So I just asked her that we have ruled out tuberculosis by doing these basic tests. Looks like sarcoidosis. I would like to start you on, since you are having symptoms, I would like to start you on small dose of steroid. She was very reluctant to start a small dose of steroid, but after 2-3 months, she had ocular sarcoidosis, and she had to be started on 60 mg of prednisolone.
No, again, that is the problem. No, a lot of times, why we do a biopsy is to actually have a diagnosis. Or sometimes radiologically it might fit in. Once you have a saying that it's you have cultures negative and you have a granulomatous inflammation, then it might be a little easier to convince the patient to start on the medication. Here, probably this sarcoidosis per se rather than sarcoid-like reaction, right?
So generally, we've seen that at least in patients who are having an oncological disease background are not too averse towards doing a repeat biopsy if we say that this is necessary. I think it's just a matter of counseling them and spending more time with them, explaining to them as to what is the ultimate objective of achieving that. We would be very happy if we come to know that whatever the mediastinal nodes are there are negative for a malignant disease, and of course something which can be treatable, and that should be the primary objective for all of us to explain out and explain the whole situation. Maybe if they don't agree at the first sitting, ask them to come back after a week with a clear thought, again sit with them, talk to them, take a time of about 3 weeks to 4 weeks to reassess with a scan. That's what I do in practice, and I'm sure all of us would be doing the same. Prashant sir, your opinion?
I think you said a very important point. As time is going, we've started to say, we've taken it easy. We give patients time to think.
Yeah.
You don't create a panic. But
Yeah.
you explain. And inadvertently, 8 out of 10 patients will have had a think. They come back and say, doc, we want to go ahead with the procedure. So I think the point is, we don't have to push at the first point. Abhi ke abhi karao. There's no panic situation. He's had it. Yeah.
Yeah, and I agree that we are in an era of shared decision making where all options are to be put towards the patient across the table, and then we both actually make an informed decision to do it.
And a lot of time, your concern for the patient is misinterpreted by the patient as something each for your own good.
Yes. So I think it's at that note, I think we should call this session to an end. Sir, any closing remarks?
Thanks a lot. I mean, all of you guys waited. I think it's a very practical discussion. Next time, I promise, I've told the honest, we'll do it on a Sunday or Saturday evening from 7 to 9. Yeah, but thank you so much.
Sure.
I really
Thank
appreciate it.
Thank you.
Thanks to the guys who traveled from Coimbatore.